My name is Charmaine Bukovets and I'm the Executive Officer of TBV. Our first webinar tonight is titled Racing to Success, which will focus on updates on the following projects: Racing and Injury, Diagnostic Imaging and Radiography in Yearlings. Our other 5 webinars will be scattered over the course of the next few months, with our next one in February, which will be on welfare. The other webinars that we will be hosting will be on foal care and health, horse health, pregnancy and fertility and pregnancy. So we hope to see you back there again. Just some housekeeping. We will have some short presentations from 3 speakers tonight, and we'll answer questions at the end of each segment. So if we don't get to your question in this time, we will endeavour to follow up with you post the meeting tonight. And if you can keep your speakers on mute while we are going through the presentations, that would be fabulous. Finally, this session is recorded and the recordings will be sent to you next week, we hope. So if you have anything you want to go back on, you will you'll have the recording there. So sit back, relax, and we hope you enjoy the night. And I'd like to introduce you to Annalise McGaw of AgriFutures, who will kick off the next segment.
So thank you all for joining us today. My name is Annalise McGaw. I am the Program Manager for the Thoroughbred Horse Program with AgriFutures, which invests thoroughbred breeder funds and other industry contributions in research for the thoroughbred industry. So I just wanted to quickly go through a couple of things that we do here at AgriFutures. So to start with, the thoroughbred horse levy is $10 from every mare paid by the breeder, and then $10 from every mare served but paid by the stallion owner. So we currently have 23 ongoing research projects, and some recent key achievements from the program includes management of heat stress of stallions, a quicker test for both chlamydia and herpes, some heart muscle scarring and sudden death research, and then also other industry support, for example, around the fast track training program. Then at the present time, we are about to start developing the next strategic 5-year plan for the Thoroughbred Horse Program, which defines and guides the investment from the investment of the levy and the matching industry contribution and the matching Commonwealth contribution into the research that we do. So on your screen at the moment is the current 5 priorities from the current plan. But like I said, we're redeveloping these for the next 5 years. So in February and March, what will happen is that a proposed plan will be available for public consultation. So I'd really like to suggest that you guys get engaged and have a look at that and see if that meets your needs for research and development with the investment of the levy. And so we will get that out through all the state organisations and the national organisation. We'll also get that out through all our newsletters that we do as well. But if you don't find a copy, you don't see a copy in February, let me know and I'll be able to send one across for sure. So that was about all I had to talk about the program at the present time. I'll now do a quick introduction for our speakers for tonight. So our first speaker will be Tunde from the University of Melbourne, who'll be talking about sesamoid bone injury and repair. He's one of Chris Whitten's groups down there at the University of Melbourne. Then I'll have Dr. Alex Young from the University of Queensland, and she'll be talking to us about diagnostic imaging. And then Dr. Ben Ahern from the University of Queensland will talk about radiography in yearlings prior to sale. So I'll now hand over to you, Tunde, and we'll get going. Thank you.
Thanks, Annalise. I will share my screen now. Thank you, everyone, for joining us today, and thanks to AgriFutures for the invitation to talk about the project our research group at the University of Melbourne is working on, looking at how proximal sesamoid bones in thoroughbred horses adapt to training. And my name is Babatunde Ayodele. You can call me Tunde, and I work as a research fellow with the Equine Orthopedic Research Group led by Chris Whitten at the University of Melbourne. So I'd like to start with a bit of anatomy showing the location of the proximal sesamoid bone and their importance in the horse leg. So the proximal sesamoid bones are relatively small triangular bones that form the fetlock joint together with the condyles of the cannon bone. And that's what we refer to as the third metacarpal bone and the long pastern bone, which is the first phalanx. So there are two proximal sesamoid bones in each fetlock joint, normally in close contact with the back of the lateral and medial condyles of the cannon bone. So if we look at the connection of the ligaments around the fetlock, we can see that the sesamoids are attached to by the suspensory ligament, which is colored in yellow there. And in fact, the sesamoids provide the support. So it's like an anchor for the fetlock joint, which is required for movement. So if we look at the data on the cases of fractures occurring in thoroughbred horses around the world, we can see that fracture of the proximal sesamoid bones are quite common. So in Hong Kong, sesamoid fractures account for about 55% of all fractures where death occurred. And in the United States, sesamoid fractures can be as high as 50% of all fatal fractures. The actual number of sesamoid fracture in the UK is not certain, but it is believed to be lower than the fracture of cannon bones and also lower compared to data from Hong Kong and the United States. So the question is, what about Australia? So the data available for New South Wales and the Capital Territory indicate that sesamoid fractures account for about 21% of all the fatal fractures. And the data available for Victoria from back in 2007 showed that sesamoid fracture is about 70% of all fatal fractures. So relatively, Australia, cases of sesamoid bone fracture is not as common in Australia compared to Hong Kong and the United States. And this may be related to the differences in the way the fetlock joint is loaded with different racetrack surfaces. So the most important message here is that fracture of the proximal sesamoid bone can be fatal and it can lead to significant loss of valuable horses. So previous research from the United States, where they have studied the history of horses that died due to sesamoid fracture, has identified some of the risk factors associated with sesamoid fractures. So the risk of sesamoid fracture is higher when horses have higher exercise intensity, particularly the entire males that generate high magnitude joint load during galloping. So likewise, horses that are older and those that have longer racing career, or those that have accumulated a lot of racing distance are more likely to sustain sesamoid fracture. So what these risk factors are telling us is that these fractures are due to changes that had occurred in the bone over time during the repeated loading of the fetlock joint, especially over the racing career of the horse. So these fractures are what we call fatigue bone fractures. They occur due to changes that accumulate over time with repeated bone loading. In addition to the risk factors that have been identified, there are also a few studies that have shown changes in the structure of sesamoid bone that sustained fractures. So one consistent finding from this study is that the amount of bone tissue present, so in the fractured sesamoid, is higher than sesamoids that had no fracture. So this observation is consistent with what we know about the cannon bone where fatigue fracture occurs, whereby the bone becomes very dense with a lot of bone damage accumulated. Another observation made was that many of the sesamoid bones that fractured had an area where bone tissue is lost. So that's an area of bone lysis, especially on the palmar side, the area away from the cannon bone. So this area is indicated here on this image with a white ring. And this kind of lesion is usually considered as the weak point through which bone fracture can be initiated or propagated in the sesamoid bone. So the other common feature that we see in the cannon bone with fatigue bone fracture is the accumulation of bone microdamage. And the bone microdamage are tiny little cracks, as you can see from this image. So this image was taken from a cannon bone. There are tiny little cracks on the surface of the bone, and they accumulate in large number in bones before fracture occurs. But we are not very certain that microdamage accumulate in sesamoid bones in relation to fatigue fracture. What we also need to know is how proximal sesamoid bones adapt to training and racing conditions, and how this can lead to fracture or cause some of the changes that were observed in fractured sesamoid bones. So in addition, it will be very useful if there are other changes in the sesamoid bone. It will be very useful to know if there are other changes in the sesamoid bone before fracture occurs. So this information is important to help us understand how training and racing conditions can be modified to prevent sesamoid fracture, and also to identify horses that may be at risk of sustaining sesamoid fracture earlier. So we collected the two sesamoid bones from one forelimb of 63 thoroughbred horses during postmortem examination and performed micro-CT imaging. So this imaging can help us to examine the bones more closely with better resolution than what we can obtain doing normal CT scan of the whole leg of a horse. So using the micro-CT, we can see lesions more clearly, and also we can determine the quantity of bone or the quantity of mineral in the whole sesamoid bone or in different regions of the bone. So from the results of our experiment so far, we compared, when we compared the amount of bone tissue present in the sesamoids between medial and lateral bones from the same forelimb, we found that the medial sesamoids have more bone tissue when compared with the lateral bones. And this is consistent with the fact that the medial sesamoids carry more load than the lateral sesamoids, especially during fast exercise. And this also could be the reason why the incidence of fracture is more common in the medial sesamoids than in the lateral sesamoids. We also looked at the different regions of the sesamoid bones to determine how bone structure may be different between the regions. There was more bone tissue in the mid-body region of the bone compared to the basal and the apical region of the bone, and especially in the area which is in direct contact with the cannon bone. Also, we noticed that most of the differences we saw in the quantity of bone between the medial sesamoids and the lateral sesamoids were mainly due to differences in the apical region. As you can see in this image, there are more pores in the apical region of the lateral sesamoid compared to the apical region of the medial sesamoid. One of the results from our study also showed that greater sesamoid bone quantity was present in horses that raced, especially in those that were 2 to 5 year olds and in those that started racing early. So if you compare these two images of the medial sesamoids of two horses, the one on the left is from a 2-year-old horse that had not raised at all, and the one on the right is from a 5-year-old horse that had raised. You can see that there are more white areas, which represents the bone in the image on the right, showing that there are more bone tissue in the sesamoids from the 5-year-old horse compared to the bone from the 2-year-old horse that had never raised. So this is an evidence of an adaptive response to loading of the bone as more bone tissue is laid down with repeated exercise. So another important result that we saw was that the quantity of bone present in the proximal sesamoid bone is higher for horses with lower handicap rating compared to those with mid and high handicap rating. As mentioned earlier, sesamoid bones with fracture have been observed to have higher bone quantities. So what this result is telling us is that those horses with low handicap rating have higher bone density, may have overworked, and likely to have developed changes that are causing soreness, which is in turn affecting their performance. So soreness is very common when the suspensory apparatus is overloaded, or when there is an impending sesamoid fracture, sesamoid injury. As I will show in a moment, some of the sesamoid bones have abnormal changes, especially on the articular surface and on the apexial surface at the point where the suspensory ligament attached to the sesamoids. So we also examined the sesamoids for lesions, and we found some. So the subchondral bone microdamage, these are the tiny little damage that accumulate on the articular surface, especially in area where the sesamoid is in contact with the condyles of the cannon bone. So we were able to identify this sort of damage in 67 out of the 126 bone samples examined. Although this is not comparable in size to what we have seen in the condyles of the cannon bone, where the microdamage are larger, as you can see from this image taken from the parasagittal groove, the cannon bone. So this sort of damage accumulates in large numbers within dense area of bone. You can see that the bone has more, this area of the sesamoid has more bone tissue, and so we expect to see those tiny damage in this area, and which is an evidence that the sesamoid bones are getting fatigued. So in addition to the subchondral bone microdamage, we found areas where focal area of bone loss had occurred around the articular surface in about 36 samples out of 126. And we also identified areas where there were focal bone loss in the apexial surface. That's the area where the suspensory ligament attaches to the bone. And as you can see, there are sesamoid bones with a lot of bone tissue. These are sesamoid bones with, a lot of bone tissues. And these lesions are the ongoing changes we see in bone samples as the bone tissue accumulates with repeated loading. So the take-home message from my presentation is that changes we have seen in the proximal sesamoid bone of thoroughbred horses in training is similar to those changes that had been observed in fractured sesamoid bones. And these changes are consistent with repetitive loading of the fetlock joint, exceeding the fatigue life of the sesamoids. And this highlights the fact that there is a potential to reduce fracture risk by modifying training methods. And as we reduce fracture risk, there is potential also for sustaining better performance in the horses. And the story does not end there. We are currently looking in more details at the balance between bone formation, and bone resorption in these samples to better understand how much they adapt under different training and racing conditions. And for that, we're using different techniques, including electron microscopy and advanced staining methods to quantify the level of bone formation and resorption, so that we can relate that with biomarkers that might be circulating in blood and use that as a way to detect or find out what's happening in the bone by just taking blood samples. So many thanks to AgriFutures for their support of this project. And to finish my presentation, I'd like to acknowledge all members of our team that I am working with on this project. And thank you very much. You can take your questions.
Thank you, Tundi. That was a great presentation. I learned a lot there as well. Did we have any questions from our guests at the moment? We have a raised hand from Ben, or that may have been.
I was just going to ask if you saw a difference in those microfractures between medial and lateral sesamoid bones.
Very good question. No, we did not see. Yeah, so there was no difference there seems to be more micro damage in the medial bone, but we're not statistically different between lateral and medial.
Interesting, thanks.
Does anyone have any other questions at the moment? No? Well, look, if you do and you think of it later on, feel free to, when we send out the recording, feel free to send an email back and we can go from there. Tundi, thank you very much for your time. It's greatly appreciated.
Thank you.
Fabulous. So next speaker is Dr. Alex Young.
I wanted to start by acknowledging and thanking AgriFutures for the support for this research and for the invitation to speak this evening. My background is, before I do my background, I also want to acknowledge my co-investigator, Dr. Georgina Johnson, who did this work under her DB ClinSci program at the University of Queensland as she was training to become a specialist in equine sports medicine and rehabilitation. And this was quite a Herculean effort on her part and a big project. So I really take my hat off to her. My background, just quickly, I grew up in the thoroughbred industry. I always sort of thought when I went off to vet school, if I wasn't going to be a horse vet, I'd look for something else in the thoroughbred industry as a career path. But I actually really love the veterinary profession and the opportunities it's given me to contribute, hopefully in a positive way, to the sport of racing. I'm currently a diagnostic imaging specialist in equine imaging at the University of Queensland. So I guess if we could click to the first slide, Tundi's already talked a little bit about this concept of musculoskeletal adaptation. And as we're training horses, we're not just training their cardiovascular systems, we're training their musculoskeletal systems. And it is perfectly normal and appropriate for the bone to remodel in response to the forces placed upon it. So the image of the cannon bone that's in the bottom left of this sequence of fetlock images, whoops, go back, thank you. The one over the left is a racehorse fetlock, the bottom of its cannon bone, the sesamoid bone, as Tundi was just pointing to. And we can see a very nice, thin, bright white cortex, which is the strong part of the bone. The centralized, more gray area is the sort of the shock absorber part of the bone. And we're centered on the condyles there in the sesamoid bone. As we progress across those images from left to right, we can see progressively increased amounts of white, which is new bone, new mineral within that, what is supposed to be a spongy shock absorbing bone. So with time, although this response to training is normal to some degree, we do start to get an increase in stiffness in the bone. It becomes a little bit more brittle, and we can start to see those micro cracks that Tundi was just showing us on a micro CT level. And if we don't catch those bones before we keep pushing them, we have the potential for those micro cracks to coalesce and then to become, actually, if you could click, sorry, one more slide. I mean, you've seen some micro cracks from Tunde. It should just, that's another histopathology, oh, sorry, micro CT slide. And then if we click to the next one, this shows us what happens when they finally do coalesce and become a catastrophic fracture. So the trick for us is, how do we pick up these horses as they're transitioning from an appropriate level of musculoskeletal adaptation into this danger zone where we potentially can end up with a very significant injury. So if we flick to the next slide, please, Annalise. Obviously, the role of advanced diagnostic imaging has been really receiving a lot of press lately, particularly after the Spring Carnival we've just had. I mean, Australia is the first in the world to have tried to do a screening protocol before some big races. And for those who aren't familiar with the term advanced diagnostic imaging, it really refers to the imaging we do that isn't X-ray or ultrasound. Those are kind of our starting point, our workhorse modalities, but these modalities, these advanced modalities, have gradually become more and more accessible to our equine patients. And as a result of that, we are learning more and more about the tendon pathology, the bone pathology that we once upon a time saw to some degree with an X-ray or an ultrasound, but we now have much more information available to us regarding the health of those bones and tendons and ligaments. And we can start to use that information not just in our lame patients or horses presenting to us for a lameness problem, but we can start to potentially use it to assess this adaptive musculoskeletal remodeling and ideally try to identify the ones that perhaps are entering that risk zone. So if we could please go to the next slide. To address that, or to try to start to look at that, our research objectives focused around the fetlock, because this is our most common location of fracture in the racing thoroughbred. And our first port of call here was to look into the imaging appearance of these fetlock changes in our local population. So we're in southeast Queensland, and we wanted to compare these to the pathological appearance. So we could use the gold, we could use the gold standard of opening up a fetlock and looking at it, physically, and cutting into it and looking at the health of the bone and the cartilage, and then we could use that to help us interpret our advanced imaging more accurately. The next one, if we could flick on, please, Annalise. Thank you, was to now then look at these findings across different imaging modalities. So if there is something there, can we see it on X-ray? Can we see it on CT and on a standing MRI? And if we can or can't, or how does it look, we can take that information back to our hospitals and our clinical patients and say, righto, well, if I have a horse with a fetlock problem, what are the strengths and weaknesses of these modalities? Which tests should I run in order to try to detect this pathology? And then the third objective, that we hope to identify any trends or common imaging findings in these cases, which potentially might be able to serve as a marker for these horses entering the potential imminent catastrophic injury. And if we can identify those before in this population of horses that have some fractures, we can work backwards and say, well, if we're scanning our clinical patients and we see this sort of finding, is it an increased or elevated reason or concern for increased risk? So in order to achieve these objectives, we started to collect thoroughbred racetrack fatalities in southeast Queensland over a 2-year period. These horses were either in training or racing and may have died or been euthanized for various reasons, and they may have had a fractured leg, or we also included horses that did not have a fracture. The next point, please, thank you. So once we had the limbs in the hospital, or the horses in the hospital, or the limbs themselves, we would disarticulate the limbs. We would put the fetlocks through each of these various imaging modalities. They would have X-rays, they would go through the MRI, and they would go through the CT. And then finally, we also then opened them up, had a direct look at them for gross pathological examination, and where there was something of interest either on pathology and or the imaging, we could then target those areas more specifically with histopathology, which is more just information at a cellular level of what's happening, or microscopic level. So if we could please flick, thank you, Annalise. So there's a number of different projects under this research, and don't worry about reading all of those different project headings. I'll go through one by one in relation to what we found. But the first thing we found that we needed to do as we were collecting these limbs for imaging was that we realized we weren't always, for logistical reasons, able to image them as quickly as we would have liked to. And for that reason, we needed to refrigerate or freeze them so that they didn't decompose and start to get all icky and start to mess with our results. But this then brought its own concern that, well, if we're freezing these bones, is there a chance that we will alter their findings, their pathology, their cellular makeup? And so this could have potentially interfered with our results. And there was a particular finding on MRI we were most interested in, and that was what we call stir hyperintensity or bright signal. And most often it's a fluid signal that we see within the bone. And as you can imagine, if you've got fluid in a bone and you freeze that bone and then you thaw it out and you image it, we could potentially be altering the characteristics of that fluid. So we could just click forward, please, Annalise. So the good news for our research in this particular study was that the images at the top, which show some bright circles or bright areas of signal, which is the fluid signal within the dark, otherwise dark bone. If you look above and below, they pretty much were the same before and after the freezing and the thawing protocol that we used. So this was really good news for our research. It meant we could proceed with all the imaging. We published, if you could click, Annalise, please, we did publish this earlier this year, and this sort of information would be very valuable also to researchers worldwide who are concerned they may be messing with their data if they're freezing limbs. So we hope that this is of value to people internationally. If we could click forward to the next project, please, Annalise, which was to look at the gross pathology appearance of our fetlocks in this population. And I know I've skipped over the imaging to go to the pathology that happened at the end, but I guess it's important we understand what our particular population had for pathology, and then we work backwards on what that was all looking like on the imaging. So if we click forwards, we ended up with 20 thoroughbred cadavers. That gave us 80 fetlocks. And if you click, please, Annalise, we were able to break these up into smaller groups. We had a group of 5 horses that had fetlock fractures. 4 of these were sesamoid fractures, and there was 1 transverse, which is kind of like a horizontal fracture of the bottom of the cannon bone. Interestingly, we didn't have any condylar fractures in this group, and this was similar to an epidemiological study that came out looking at our southeastern population around the same time, which said that sesamoid fractures are more common for our particular population. But it was of interest, and I'll get to it later, why we didn't have the parasagittal, the condylar fractures in this group of horses. The next point was our other fracture group. We had 6 horses that did sustain fracture, but not at the fetlock, somewhere else. So we had humeral fractures, tibial fractures, and a cannon bone fracture up by the level of the tarsus or the hock rather than the fetlock. And then our final group was our non-fracture group or our control group, which were the horses that were dying for non-musculoskeletal reasons. So we had 7 sudden deaths and 2 horses with colic. So if we could, thank you. Just quickly touch on, there wasn't anything here that was that alarming with regards to our findings. All our fetlocks had gross cartilage changes or discoloration, and that's very consistent with what other populations have been shown to have on their pathology studies. Palmar or plantar osteochondral disease, or POD, which most people may be familiar with that term. It's a very common injury that we see at the bottom of the cannon bone. In our population, again, very common, 88% of limbs. But what was of interest to us was that most of the time those were symmetrical, those pod lesions. And we found that when we had markedly asymmetrical pod lesions, as you can see, one condyle is very bruised on this cannon bone and the other condyle is not too bad. These asymmetrical pods were statistically more common in the fractured group. So this concept of, fetlock fracture, I should say, this concept of asymmetrical pathology and potentially asymmetrical loading of the bones meant that although pod was quite ubiquitous, once it started getting asymmetrical, that did seem to correlate more with the fetlock fracture group. So the next, if we could flick to the next one, please. This is the, I guess, the meat of the research and the really where we were heading with all those other bits we've done, where we wanted to really focus on our imaging and the pathological appearance of abnormalities in the parasagittal groove of these cannon bones. And if you could click the next image, please, Annalise, the parasagittal groove. Oh, that's really, there we go. Sorry, it looks really grainy for a minute. The parasagittal groove I can't point to, but basically where that fracture line is coming up from, that's the parasagittal groove. And this is where condylar fractures start, and therefore an area of great interest, because as an imaging specialist, I often see changes in those parasagittal grooves and don't always know what to make of them. Some of them are straightforward, this one's a fracture, but others we don't know. Are they the beginnings of a fracture? Are they something to be concerned about, not concerned about? So we were very interested in exploring the imaging and pathological appearance of this region. So if we could flick, please, Annalise. So we had a couple of hypotheses, which I'll go through in relation to the findings, just in order to save us a bit of time. But with regards to our methodology, we have the same 80 fetlocks I've talked about already. They all underwent the extensive imaging, and then quite a detailed grading system for each modality. And this took hours to go through and in great detail separate out all the different findings so that we could then go back with our data analysis and compare and look for associations between some of these findings at both the horse level and the limb level. So if we flick to the next slide, the hypotheses, our first hypothesis was that CT and MRI would be superior to X-ray for changes in the parasagittal groove region. And this was true. Yes, we see things with CT and MRI that we most definitely miss with X-rays. And that's not a great surprise to those of us who are doing a lot of imaging, because we know that an X-ray, as is the image on the bottom left there, has a lot of superimposition on it. So for me to look at the cannon bone or that parasagittal groove area, I need to look through the superimposed long pastern bone. And I've got sesamoid bone sitting just over the top of the bone, just above that. So you sort of have to magic eye book it, and you're looking for subtle changes but looking through other bones to get there. Whereas when we talk about CT and we talk about MRI, these are images that we've obtained in a slice by slice fashion. So it's like taking the big tube of salami at the deli and slicing it up, and instead of having to look at that three-dimensional thing in a 2D flat image, we now have every one of those little circles that we can evaluate independently. And in this particular case, that CT image in the center where I can't point, but at the parasagittal groove, thanks Annalise, there are some small gray, almost linear, that's the one, thank you, on both sides. There's some very subtle changes in there that absolutely are not visible on this radiograph that goes with it, and have been in the past hypothesized to potentially represent, could this be the beginning of a fracture that's starting to propagate up through the bone? And so that is something that may be a significant finding, and yet we wouldn't be able to see it on an X-ray. If we go to the next slide, please. We also found that CT was superior to MRI for the detection of certain bone and cartilage changes. And this also is a very logical finding. CT is a 0.5 millimeter slice by slice compared to a standing MRI where we're looking at 5 millimeter thick slices. So there is the potential, if something is subtle and only very small, we could skip over it with our MRI slices. But the other changes, such as the sclerosis, if you look at that corresponding MRI image, although I can't see those little linear defects or changes in the CT, I can certainly see that there's a change in the blackness of those condyles, and there are some adaptive changes there. If we flick to the next slide, the MRI has other strengths. So MRI is superior to the CT for functional information. And in particular of interest is this fluid signal or stir hyperintensity I referred to in the freeze thaw paper, where basically we will see within what should be a black bone an area of white signal. And that white signal tells us there is activity there, there is remodeling, and something is going on in the bone. And we have images of fetlocks that look like this, but then on a CT, we can't find anything. Structurally, the bone looked normal on the CT, and yet on the MRI, we have evidence there is activity there. Now, that activity may be in the realm of adaptive. I'm responding to my training regime and I'm perfectly acceptable stir hyperintensity. But it could also be stir hyperintensity or fluid signal saying, hey, I'm full of micro cracks and I'm imminent, fracture waiting to happen. So this is an area that we need to learn more about, and especially in a CT where we won't see necessarily the structural changes, this can be very important. So these two modalities, the CT and MRI, have different strengths, but together, when you put all that information together, you have a more holistic picture at the end of what's going on within that bone. So the next hypothesis was that certain imaging planes would improve our ability to visualize these changes. And I'm not going to go too much into the detail. This is quite a nerdy part of the study, but for us that are acquiring these images and interpreting these images, it's quite critical that we know we're slicing them in a way that optimizes our ability to find the problem. So if we're slicing it one way and we're potentially missing it, but we slice it this way and we can see it, and I just realized you can't see me, so you can't see my hand movements, but basically you just want to slice it in the correct plane to pick off the pathology. And we found a couple of changes in technique or protocol could improve our ability to detect changes in this study, and that's of value to people who are doing CT and MR and maybe might want to adjust their protocol accordingly. And then finally, we really hoped, our hypothesis was that there would be certain advanced imaging findings which were more prevalent in the horses with a fetlock fracture. So if you click one more, this to me is the holy grail. This is what we all are trying to figure out. Is there something in their physical exam? Is there something on their imaging? Is there something in their blood work? Is there something about the way they respond to their training that should serve as a red flag for us that this is a horse whose bones are moving past that adaptive remodeling and into the problem zone? And that's really something we hope to maybe tease out of this study. So one thing, if we flick to the next one, that we found was that despite the fact that we didn't have any condylar fractures in this particular population, it didn't mean we weren't still finding different changes in this location. So here I've got two examples of, again, some small little grey areas in those parasagittal grooves, and the image on the right almost looks like it has a little notch or a little defect. And these are changes that certainly have been hypothesized, or people have stared at and thought, oh, is this the beginnings of a fracture? And in the past, that might be something we would recommend backing off that horse, pulling it out, scratching it from the race sort of situation. But if we're seeing these commonly across all groups in this study, whether they be fracture groups or non-fracture groups, and commonly in this population, despite not having a high number of condylar fractures, it suggests that some of these may well be incidental. And I think that's important knowledge for us moving forwards, so that we're not being unfairly critical of this finding and then potentially pulling horses out unnecessarily. The next slide, please, Annalise, was also a very valuable finding, which was that the sclerosis that Tunde talked about and that I mentioned earlier within the condyles, as I said, it's an adaptive response, but when we started to see asymmetry from one side to the next, so that MRI image shows a large black area on the inside of the cannon bone and a not so black area on the outside, that asymmetry was more common and statistically significantly so in the Fetlock fracture group. So 88% of our Fetlock fractures had an asymmetrical sclerosis, compared to a 29% in the group that were fracturing their limbs elsewhere, and 17% in our control group or our non-fracture group. Also, when we looked at the fetlocks opposite to the fractured leg, so if they fractured, sesamoid fracture of the left front, and then we looked at the imaging in the right front, we also found there was a trend towards increased asymmetrical sclerosis. So this to me is something I will, certainly as an imaging specialist looking at these studies moving forward, have on my radar as something as a possible increased risk for horses. And there were other findings. If we click to the next slide, I don't have time to go into all the details, but it has been published now just in this last month. And we've received some positive feedback from our colleagues internationally, which is really nice. And I'm looking forward to seeing how we can utilize this information in our clinical work and see how it influences the way we read these studies. So finally, the last project we looked at was to focus in a little bit more again on this fluid signal within the bone and the stir hyperintensity. As I said before, if we flip to the next slide, please, we don't know whether it means it's normal adaptive or if it's becoming concerning, the level of stir hyperintensity we have, but we did feel that clinically we see it very commonly. So our hypothesis was that this signal change would be quite ubiquitous in this population. And we also felt that clinically we often see different patterns of this intensity, and the distribution varies a little bit from one horse to the next. So could this potentially indicate different pathologies if it's in different locations? And in humans, in the human literature, they've shown that different patterns of this particular fluid signal in the knee has been correlated with a specific type of injury and an inciting cause. So basically, they have a bit more information than us right now about what it could mean, and depending on where it is and how bright it is, it might mean something different. So if we flick onto the next one, please, Annalise, we had, as expected, quite ubiquitous stir hyperintensity. 97% of all the fetlocks had some degree of stir or signal change somewhere, but we did observe some different patterns within the different groups. The Fetlock Fracture group tended, we noticed, to sort of have discrete patterns. They were in discrete locations. This particular case had a fractured cannon bone on the other side. It was a transverse fracture, not a condylar fracture. And some of the orientation of this signal very much matches the plane of that fracture, and then has a more diagonal orientation to it, which was of interest to us. And the next image to come up is an example of very asymmetrical fluid signal, which is interesting in the face of what we saw of that sclerotic change and that densification of bone. If we go to the non-fracture group, they tended to be more symmetrical. They may still be quite intense, and this was a horse that had quite severe pod in both condyles. And if we go to the next one, we did also sometimes see very diffuse, maybe not as intense, but still symmetrical areas of fluid signal in this group. Now, we didn't have high enough numbers in any one of these groups to draw any sort of statistical significance or definitive conclusions. This was more, it ended up being just really interesting and helpful, looking back at some of the changes we saw in the other parts of the study to then layer this in on top of that. But people worldwide are still trying to get to the bottom of what this stir hyperintensity means, and whether it's a good thing, bad thing, or somewhere in between is something that we're all working on. So if we can go to the next slide. Thank you. The last slide, I guess, moving forwards from here, what can we do with this information? You know, we've just done all of this. Does it help us? Well, we certainly do have a better understanding now of the musculoskeletal injuries we have in our Southeast Queensland racing population, but a lot of what we found is still applicable to our Australian population and even the internationals. You know, as Tunde was talking about the prevalence of, you know, some places have more sesamoid bone fractures, some places have more condylar fractures, and this sort of data is still of interest to those other jurisdictions. The next point was we were able to identify some optimal advanced imaging techniques for the detection of the different pathologies. And as I said before, hopefully this means people can maybe modify their protocols a little bit, or make sure they include that particular imaging plane to catch that slice, to catch that lesion. And then the next point is that we did find some imaging markers that potentially increase our level of perceived risk for imminent significant musculoskeletal injury. And on the flip side of that coin, we found things which potentially are quite common, and maybe we shouldn't overinterpret or have unnecessary cause for concern with those findings. And that knowledge helps us as radiologists, as surgeons, as sports med people who are trying to advise, you know, the primary vet that's in charge of the patient, the trainer, the racing bodies, people trying to make decisions on these horses and their ability to keep running. This is all very helpful information. So hopefully we can start to incorporate that further into our analysis of these studies and advise you more accurately. So I'd like to thank once again AgriFutures for the support of this project and the others that we collaborated with on this research. I'm happy to take any questions.
Thank you, Alex. We've got a hand up from Rebecca Jamison Jones. Rebecca, did you want to take the floor?
Hi, I just wanted to ask, I was just thinking about that with the horses, with the non-fracture horses compared to the fetlock fracture horses, did you see changes in the non-fractures that, if say that you were doing screening of the horses, that you would be more concerned about a certain horse, that, for example, that was in the non-fracture group than one that obviously clearly had a fracture of the fetlock, but with all other changes and the histology and everything like that, I guess I'm trying to get to the point of, with these scans before, say, the cup or whatever, were there any results that showed that it was harder to predict? And some of the non-fractured horses, you would have thought, or maybe that there is significant injury there, that could have been a risk in a fracture, even though obviously in these cadavers it wasn't how they died.
Yes, and that was a limitation of our study, in that even though the non-fracture group was technically our control group,
yeah,
I can't tell you those horses weren't packing a bad fetlock around the track. We didn't have, and we would never really be able to get, if I were to approach the connections of that horse and say, we'd really love to know if this horse had any history of joint injections or a lameness, in this leg. That's sort of a hard thing to get. So it's very hard for me to know, even though it may have died of colic, maybe they were managing a fetlock issue. And yes, we definitely had, in the non-fracture group, we definitely had changes in those fetlocks. So it's not the ideal control group. It's very hard when you've got an opportunistic sample, as we did, which was basically we just had to take what we could get. You can't match controls as nicely as you'd like to in a more controlled prospective sort of study. And that was something we grappled with a little bit, that our control group in that respect, we would have loved to have known whether they did or did not have a known fetlock pathology, so we could interpret their images in that context. But we just unfortunately didn't have that information available to us.
Yeah, and did the horses, any of the horses that had the fetlock fractures, show not a lot of signs of changes or issues? It just was a fracture and started, so they hadn't relayed a lot of bone and everything that's sort of been discussed, that it was just more just a fracture. Not when I say just a fracture, obviously you're looking at changes that can happen and the bone density and the fluid and everything like that, and looking for these lesions as well. Did any of those horses just show not many of those different changes in their bones, but obviously had the fracture?
So I think you're asking, were there any of the horses that fractured that didn't have pre-existing pathology? It was
yes, that's sort of.
Okay. Yeah. Okay. Yeah. No. So
Sorry.
I mean, no, that's okay. I'm just making sure I had the question straight. But no, in this particular population, and remember, I mean, as much 2 years of collecting cadavers and then only having 5 fetlock fractures, obviously we would have loved to have larger numbers, to have more statistical, more robust, statistical analysis. But in our population and the fractures that we had, they all had evidence that there was pre-existing pathology. Yes.
Right.
I don't think any of those, of the ones we collected, none of them just went out and took a bad step and, it was bad luck. I think it was the result of repetitive stress loading, and it just went that bit too far.
Yeah. And that's, I guess, the whole importance of the research that's being done. So, so thank you.
Yeah, no worries. My pleasure. Thank you for your question.
No worries.
Alex, I've got a question for you. You talked in your presentation about the Holy Grail. Do you think it exists? And how do you think we go about maybe trying to find it?
Well, I think I do think it exists, but maybe I'm just an optimist. I think it's complicated because I don't think the Holy Grail is just one thing that you look at in isolation and tick the box. You just don't look at it and say, there's that finding, that horse is going to break its leg. I think it's got to be contextualized amongst all the other pieces of the puzzle, and it may mean that to achieve the Holy Grail, it might be a constellation of different things. You know, what sort of track are they on? How old are they? Those other risk factors, epidemiological risk factors that Tunde pointed out earlier, perhaps need to be layered on top of, you know, the imaging works into that. They can't be seen in isolation. So I think that to try to approach that Holy Grail from an imaging perspective and what we can contribute on the imaging front, as in which pieces of the puzzle we can bring, I think what we need to be able to do moving forward would be to follow horses instead of looking back on them and say, this one broke its leg, look what it had. If we could follow horses that are in training, in work, and be scanning them and imaging them, we can watch the ebbs and flows of that fluid signal in the bone. We can watch the way it gradually becomes more sclerotic. And then at some point, this is challenging. You're not going to image them and not put up a flag at some point and say, I'm worried. So it's very unlikely we'd be able to image them and let them progress through to fracture to then say, oh, bugger, if we see that, that's a problem. But we certainly can learn a lot more about, you know, this challenge of, is this still in the adaptive umbrella, or do we get more worried now if we can follow them prospectively? So I think that's probably the next step for us on the imaging front, and then trying to layer that into all the other factors that, you know, that factor in, because one horse that has a certain amount of sclerosis may be just fine and it's stable, mate, you know, with the same track, the same training regime, but whatever, different conformation or different whatever, one may break its leg and one may not. And so that makes it very challenging when it's so multifactorial.
Oh, thanks, Alex. That's great.
Thanks, Annalise.
Thank you, Alex. Thanks, Annalise. I don't see any more hands up for the moment. So, Alex, thank you so much for your time. And if anyone has any other questions, we'll direct them to you after the rest of this presentation.
Sure thing. Thank you very much.
Thank you. Now, our third and final speaker tonight, we're leaving the best to last, as we went with before, is Associate Professor Ben Ahern.
Okay, well, thank you very much. Again, as everyone else has done, thank you to AgriFutures for the funding support for this study and the opportunity to present it tonight. My presentation is going to be slightly different than Tunde and Alex's in that theirs were mostly complete. This one is, the study I'm presenting is in early phases, so we'll go from there. So the presentation is on radiography and Yearlings. I'm up at the University of Queensland. I get the fortunate pleasure of working with Alex, which is great. But we're going to talk about radiography and Yearlings tonight. There we go. So repository radiographs in Yearlings. Just briefly, it's these radiographs are submitted to the repository of Yearlings, and reports are generated to both the buyers and sellers, which describe various radiographic findings which are seen on these radiographic projections, and the pathology where it does occur is identified, and then an opinion is given to the stud or buyers or sellers regarding the clinical significance of what those pathological lesions seen could be. So opinion is the textbook definition is a view or judgment formed about something which is not necessarily based on fact or knowledge. Now, that's not to say that the opinions are not valuable, but because of so many variables associated with radiography and Yearlings, and lack of pertinent research into some of the small, relatively uncommon lesions, that we often are making judgment calls based on imperfect information. So that's the concern we have. When these radiographs are viewed in the repository, a description of pathology follows a protocol generally. veterinarians would say there's a such and such type of lesion, it's in such and such a position and such a certain size and shape. So, for example, on the right here, we'd say there's a medial femoral condyle cyst. And you give it a measurement in size, so it'd be 2.5 to 3 centimeters dilated in size, and we could even give it a certain type of sub-categorization if we wanted to. And over years, the radiography has improved. So the top one there is a computer radiography or an older version, and then the bottom one there is a digital radiography, which is much clearer. And the top one looks like it's looking through some fogged up window, and the bottom one's much clearer. Which means that we're finding a whole bunch more lesions, and which means we have to sort of try and make a judgment call on what those lesions mean. And in the repository, where veterinarians will say, well, the significance is low, moderate, or high, or unlikely, questionable, or likely. And then it depends on, then you start to get comments about shouldn't be raised to 2-year-olds, should be allowed to mature. There's a whole bunch of interpretation which goes on in there. So the research we're undertaking and just commencing is not is being done before to some degree in some elements. One of the largest ones was done out of Kentucky with the Root and Riddle group here, also a variety of Colorado State University and some other places. And they looked at 1,100 yearlings and looked for prevalence of lesions. And they found vascular channels in those sesamoid bones that Dundee and Alex were talking about would be very common, and that fragmentation and lucency can occur. So pretty much they found that there will be radiographic changes in a lot of thoroughbreds which are presented for sale. But the problem is that the rarity of some changes will make the further investigation of what those changes mean quite difficult to interpret. Now, they had quite one of the largest study groups there of 1,100 horses. There's a whole bunch of other studies which are focused in on small parts. So one on top looking at sesamoid bones, one which is Chris Whitten's group, one down the bottom looking at changes in the hock, and then there's ones associated with accessory carpal bone lucencies, and some of these just look to see how commonly they occur, and some of them follow them out to look at the performance. But almost inevitably, they're relatively small groups of horses which are examined. So what do we want to do? We want to try and peel back some of the uncertainty, try and look at different groups of horses with certain lesions which are of concern, and try and get to the point we have more facts and slightly less opinion potentially. How to do that though is the conundrum, because it's difficult. The only way we can really do it is to build on previous years' experience. The issue with that is, yeah, that all sounds good and well, but really how? We can't very easily go back and reread 250,000 repository radiographs and review them all again. That would take, I think I did the calculations, it would be 5 or 6 years of potentially looking at radiographs for one person to do. So it's clearly not logistically possible. And also, currently, when radiographs are seen at the sales, there's no standardized reporting of what the template of how the report is given. A lot of the time, buyers will ask for an interpretation from veterinarians with 2 minutes or as the horse is going into the sales ring. And as a result, a lot of those reports are verbal, so hence we can't use that data. So how are we going to do it? Or how are we proposing to do it? We can't reread, the major issue is we can't reread 250,000 radiographics projections. So a solution we've come up with is that reports do exist on those yearling radiographic sets, but they're from immediately prior to sale. Normally generated for the studs or generated for other potential buyers. And a small number of facilities in Australia's region perform large number of examinations. So that means it's quite a standardized group. And our plan is to use these reports to form groups of yearlings with lesions. So if we're particularly interested in medial femoral condyle of the yearlings, then we can get a large number of horses and follow them through to see how they perform for their career. Second issue is that there's no standardization of reporting. One veterinary hospital or clinic or one veterinarian viewing the radiographs will utilize a different reporting scale compared to someone else. So a solution we've come up with for that is we're going to compare where reports are, where we've got overlap between two different facilities. We can compare the detection rate of lesions and what their significance of lesion scoring is, and potentially allow us to amalgamate large groups of data into a single larger group, and as a result increase our numbers, assuming they're in agreement. And then we can go and simply perform statistical comparison of between an expert panel to make sure that everyone's seeing the same thing and everyone's agreeing that they are lesions of specific lesions in these yearlings, and that allow us to have a large group of data in a very large Excel spreadsheet, pretty much. And then what are we going to do? Analyze that. There will be a huge number of control horses with no clinically significant lesions, so potentially up to 90%. So we still need to go and get that data because they're our control group, and that'll give us a lot of statistical power. And then we're going to compare that to whatever the lesion of interest which we want to investigate, of which there are quite a few. But which one's interesting? And what about when there's multiple lesions in a single horse? That starts to become a concern. So which ones? How are we going to answer that? We're very fortunate to have a panel of well-respected and experts in interpretation of yearling radiographs involved in this study. And through a sequence of Zoom sessions, we're going to compile all the different grading systems which are currently used, and potentially at the end of this maybe recommend or suggest a standardized one, which would improve the ability to communicate consistently with buyers and sellers and all the people involved. And then in the second Zoom session, look at joint by joint for which lesions are seen from common to rare, and then list the top 5 significant lesions, and then list the top 5 areas of uncertainty. Now, you think the top 5 top lesions of significance would be the same as the top 5 areas of uncertainty. However, they may not be true. For example, a particularly bad, a very large cyst, for example, of medial femoral condyle is a significant lesion, but that's pretty well accepted and well recognized, and there's previous literature about that. So hence, it probably wouldn't be one of our 5 top areas of concern. But we'll see. With this Zoom session, we'll work that out, and that'll be utilized to then allow us to perform subsequent case control studies, investigating particular lesions to see whether they have an impact or indeed don't have an impact on the long-term racing success of those yearling thoroughbreds. So very lucky, and thank you to have these core experts involved, Dr. Chris O'Sullivan around Randwick Equine Centre, Angus Atkins at Scone. Steve Hance is the international consultant for a bunch of the sales rings around the world. So very, very good to have Steve involved. Chris Lawler performs a large number of radiographic radiology interpretations in Australia. Myself and Alex Young, who presented just before. And then a special mention is Brodie Argue, who's online here tonight, I hear. He's recently started sports medicine, ACDSMR resident at University of Queensland. He'll be spending some of his time at Randwick Equine Centre in Sydney and up at UQ. And Brodie's going to be working on this. He's already done a mountain of work on it, which is amazing. So the next presentation of this, which will have more results, will probably be Brodie's face up here rather than mine. And then we will get additional members as topics or the specific lesion requires. So where are we at? The big pie chart there, we're the little small one. It sort of looks like Pac-Man, but we've only recently started. We have gathered the reports from 2014 and 2018 sales. We have approximately 10,000, slightly more than 10,000 full radiographic sets of reports. Now, not all of them are going to have complete data sets, so even if we work on 70% of those, 80% of those having complete data sets, so we should have about 8,000, which will be 5 to 6 times more than any previously existing study of this type. We've commenced the Zoom sessions and we're condensing the reports in a single database, which is going to take about 3 to 4 months of 2 to 3 people entering the data. It's a mountain of data to be transcribed from PDFs or various handwritten reports across into computer-based systems such as Excel, which will allow for statistical analysis in the future. And then we've also got to obtain linked long-term race records for these horses. So further to go, we need a few more Zoom sessions to drill in a little bit more with the experts. We need to cross-check and data checking. We're going to perform some inter-observer correlation assessment, statistical analysis. And then once the statistical analysis will be based off the Zoom sessions of what are the areas of concern, and the top areas will be investigated first, and we'll work our way down the list as far as we can get, and then reporting. So the study outcomes, impacts, hopefully there'll be some fact sheets regarding lesions to potentially be used for vendors or sale of repositories. For example, do lucencies in the distal metacarpus, such as the image on the bottom left there, or in the distal talus, the distal tibia of the hock there, do they cause impacts to long-term performance? Does it mean they only start as 3-year-olds versus 2-year-olds? Do they have a shortened racing career? All those type of things will be of interest and where significant. And it might be that we can conclude that a whole bunch of these lesions have very little impact. We don't really know. And then an outcome will be open access publications. You imagine when I was a new grad veterinarian, I would have loved to have gone to repositories with half a dozen publications which go through the fetlock, the hock, the carpus, the stifle, and literally go through what the top 10 lesions are. And so these are the top 10 lesions for prevalence, and these ones are particularly of interest if you see them, and as a reference point for getting everyone on the same page. I think that'll be really amazing if we can get that. And then case control studies for lesions are most concerned. So, for example, do paston cysts mean anything? Do they only mean something when they're on the medial side versus the lateral side? Are those type of things that will be potentially beneficial? And the value of this study, or the reason why it's interesting, is it's only possible by collating large separate data sets together to get something which hopefully will mean that it's statistically powerful. So the impacts at the end, it'd be nice if we had a little less opinion and more facts for veterinarians to make recommendations at sales, and for using the same a recommendation with regards to which grading scale to use, for example, will allow buyers to not get different scales from different people and potentially make more people on the same page about what they mean. Obviously, many other factors contribute to recommendations at sales. That's not going to change, but hopefully it'll be a little less uncertainty for everyone. And overall, that'll enhance buyers' sort of confidence in what some radiographic lesions from a long-term performance point of view. So I think I kept to my 15 minutes. Annalise can not be mad at me now. And just like to thank you all for the opportunity to present. And AgriFutures is a wonderful thing in Australia, to have it as a method to support research into the welfare and betterment of horses. So massive round of applause, and thank you to all the people who breed horses and submit those small amounts of money, which for each individual breeding doesn't make a huge difference, but from the researcher's point of view, means a lot of cool stuff is possible. So there's my plug for Thoroughbred Horses Australia.
Thank you very much, Ben. I think you summed that up very nicely. We are very fortunate to have AgriFutures in Australia, and there's some great research projects coming out, and I look forward to the completion of yours and all the rest that have been and more to come. Now, do we have any other questions at this stage?
Yeah, thanks, Ben. I thought I'd ask a quick question. I just wanted to get your opinion. You've been looking, both you and Alex have been looking at radiographs for a long time. I mean, realistically, you're only spring chickens still, but you've been looking at a lot of radiographs. What do you think the top 5 or few lesions of concerns will be? What's your hypothesis around this?
Big changes, so vascular channels, 3 channels, 5 channels, if they're greater than 20 millimeters, is that of significance. Sesamoiditis is a big issue in young horses going into training, and proximal sesamoid bones, when they break, are very bad. So anything we can do in that space will be good. Neofemoral condylar cysts, or cysts in general, get people very excited historically, to the point that everyone went away for them for a long time. But then a bunch of people realised that they don't always have to be a deal breaker for horses. So some people actually started pinhooking and buying them as preferable horses, and were getting away with it. So there's changes there. Each other location, the carpus, distal dorsal radiocarpal bone, changes there. Some things will become virtually irrelevant. For example, cystic changes or changes in the ulnar carpal bone, which you go back 10 or 15 years, everyone was reporting every third horse with changes in the ulnar carpal bone. And without knowledge of whether it's significant or not, everyone would just go, well, that horse is a moderate risk then, because it has a change. Most horses will have some changes. It's just which ones of them are impactful for long-term performance. So ulnar carpal bones are relatively irrelevant, to the point that people don't report them very much anymore. But radiocarpal bone changes, those type of things. Proximal plantar P1 things will probably be irrelevant, although medial may be in behind them. It'll be interesting to see. And the benefit is we've got a ridiculously large data set, which Brody had to get more hard drive on his computer just to deal with the size of the Excels he had or has. So, yeah, it'll be interesting. Thanks, Annalise.